right, the floor is yours.
Oh, okay. Hi, everyone. Thank you so much for coming, and it's so nice to see some familiar faces here. We're going to get started. Dr. Gearing, we've been working on this research project on Jewish mental health. We have actually someone here who's on our advisory board and someone who hosted us. So we're very happy that the community has really helped us and gathered around us and given us support, and we have some results to share with you. Dr. Gearing, do you want to start?
You know, like I don't know, it's great to be here. Thank you so very much, everyone, for the amount of support we received from the community really made this project possible, and at every step. So we're just eternally grateful. And the idea behind this project is that it would help improve an understanding of mental health issues and hopefully help clinical work in the future working within the Jewish.
Sorry about that. I muted the wrong person.
Okay, I can take my cue with that. I'm going to just stop.
I apologize.
I wonder if I could get one of these installed, because I think my partner, she'd love one of these for me.
Sorry, go ahead, sir.
No. Limor, did you want to start us off with the PowerPoint presentations? If anyone has any questions at any time, just chime in or put them in the chat box. We're happy to respond to either one. And we'll try to save some time at the end to answer any questions or have comment or discussion that works for anyone.
Okay. Cheers. Here. Okay. How do you want to go? Do you want?
Sure. Here's the name. Oh, we had to have a name. So there we go. That's the name. There's a lot of people on the team. There's a lot of great people have been really wonderful in helping us out. Here are some on the research team. And you have two of us here to field questions. So in the overview, we're going to just talk a little bit about some of the rationale behind the study, and then go through kind of the study protocols. We'll try to do that a little quickly, or if it's more interest, we're happy to talk more about that, and then get into some of the outcomes which we've identified and kind of next steps. So with that, I'll turn this over to Limor.
So why study Jewish mental health stigma? Okay, so there's cultural influences on mental health stigma, and we also wanted to address there was a rise in suicide among Jewish young adults here in the Houston community a few years ago. And we wanted to share our results so we could initiate a dialogue about mental health. And our results have identified targets for intervention, and we wanted to develop and expand the MH Access program, and that reaches into under-researched communities and looks at mental health knowledge, mental health stigma. It's been done in different countries. It's been done in Mexico. It's been done in China. And we really wanted to know more about the Jewish population. So the MH Access program, do you want to talk about this, Dr. Gearing? This is really your thing. Yeah.
It's part of the research center I run at the University of Houston, and it just focuses on really addressing the barriers in stigma and treatment around different communities who are often ignored in the research or not investigated. Specifically, also interested in looking at the pathways to care when someone has a mental health issue, whether they go through the formal network, which would be like a psychiatrist or social worker or hospital, or the informal network, like a community elder or a rabbi, or and often those systems have people go back and forth, which I think is wonderful, but really understanding the nuances of that is important. The other thing kind of underlining all this is for years, we've done research on some elements of this within the larger community, but typically when we mean larger community, we're meaning larger, you know, kind of white Christian community in the US. And what we found is that each community has unique differences. And if you really want to make inroads to improve mental health knowledge, access, engagement, and treatment, you need to engage in each of these individual communities for the betterment of that community. In addition, understanding all the various communities, we get a better picture of what larger influences will have across all communities. And so focusing in on underinvestigated communities, such as the Jewish community, which is very underinvestigated in this area, has a lot of strengths, both with the community and the larger field. You're muted. We're going to play like a mute game the whole way through.
Okay.
We're getting Limor, just so you know, we were getting a bit of an echo when you were talking, or when Dr. Gearing was talking, so I had muted you. So I apologize.
No problem, not at all. That's fine. Okay, so let's go over some different types of stigma. There's perceived stigma. This is the stigma that individuals believe that most people in the public have towards people with mental illness. And there's public stigma. That's stigma that individuals from the public have towards people with mental illness. And these are things like pre-assigned negative values, attitudes, emotions that people have. They discredit and devalue people and limit their social standing because of the stigma. And they consist of stereotypes, prejudice, and discrimination. And then there's self-stigma. That's internalized negative stigma from others. And so basically a person takes public stigma and applies it to themselves. And this is a person with mental illness who would be applying stigma about mental illness. And to start off with the methods, we had 38 locations, both formal and informal. So for instance, we went to the JCC. We also went to private homes. We had 494 participants. We did a survey and it was face-to-face. We did it in person, but it was a private survey that people did on laptops, on Qualtrics, and they were compensated with a $15 Amazon gift card. And the survey contents were demographic questions like age, gender, SES, time spent living in Israel, familiarity and personal experience with mental health. There were standardized scales that we'll get into some more. And we had 2 randomized mental health vignettes, and we'll be sharing an example of what that was with you. And then there were follow-up questions about the vignette. Now, the vignette is like a long paragraph describing a person with mental illness. And we'll also share with you, there were many different types of mental illness that we looked at. And so each vignette covered different ones, and we varied them by gender. So we had male and female for every type of mental illness we were looking at. And so we had follow-up questions such as, do you think there's a problem? If so, what do you think it is? We asked questions about stigma, about how the person felt about this person, thought about this person with mental illness, and then barriers and supports to treatment access. And our measures were the devaluation of consumer scale, which was a perceived stigma, and devaluation of consumer families that asked about, families that had a member of mental illness, what they perceived other people, most people in the community or the population think about mental illness. And then we had the mental illness stigma scale, and this was our main scale for measuring public stigma, what people think about a person with a mental illness. And we had the daily spiritual experiences scale. We had the everyday discrimination scale, and we had the attitudes towards seeking professional psychological help. Okay. We had an advisory board in the community, and we had members from mental health agencies such as Jewish Family Service, We had psychiatrists, we had social workers, we had community leaders and rabbis. And we got input on Houston-specific mental health issues that we used when we were designing the study. We got feedback, we got connections, referrals, and support from rabbis and Jewish organizations, from key community members. We made an advisory board, and we got a lot of good input from them about what to study, where to go, where to get connections to get access to people in the community. And we got connections to potential funders. Dr. Gearing, do you want to step in?
My turn to be muted. So it might be easier a little more to mute when I'm talking, I think, to avoid an echo. It's like a mute tag game. I love this. Okay. So in the participant recruitment, as I said, we're going to both formal and informal sites. We're looking to try a wide range of individuals within the Jewish community across Houston. We had informal ones. We went to some of the individuals' homes that were so kind enough to open them up to us and the research. Now, we finished collecting the data in February of 2020, the end of February, literally 2 weeks before COVID stormed across and has not stopped storming. It would be probably not feasible to do some of the data collection we had done then now, but certainly grateful for those that opened their doors and supported recruitment in different ways. We also had formal recruitment sites. Synagogues across Houston were very, very generous in their time and resources allowed to open up to us, as well as a number of organizations. So that was just really appreciated. We'll go to the next slide. Okay, so there was a total of, and Limor kind of noted this, that we had these vignette structures, and basically we can ask a bunch of questions to understand who's answering the survey. We can give them a brief story of somebody with a mental health issue, and then we can use a number of measures and questions to really determine attitudes and perceptions and stigma related to that. And we focused various scenarios around suicidality, which was an issue in the community, as it is an issue in just about every community, general mental health, mood disorder, substance use, and domestic violence. Most of the vignettes we manipulated. Some people got a vignette with the person in the story was male, sometimes the person in the story was female, or different ages, and we could manipulate that randomly through the software we did. So that allows for more robust findings. Continue. So here's an example of one of the vignettes. This is a suicide vignette. So I'm going to read it like it's a male who's 15, but you can see we also had a female, and they were the ages 15, 25, or 73, and everybody would get a different one, and they would know that others existed. So here it is. Over the past 2 years, Ron, a 15-year-old, has been experiencing a decline in motivation and finding it more challenging to complete daily activities and responsibilities. Ron describes feeling disconnected from and pressured by the people he cares about most, and he has increasingly began to withdraw. He describes feeling irritable, having a sad mood, and losing pleasure in most activities. Ron explains he feels almost a sense of relief when he thinks about ending his life, which he thinks about more and more. Recently, he has made a plan for taking an overdose of pills and feels his plan is feasible and realistic. That's an example of one of the vignette structures. And then we would ask a series of questions about how the person responding to the vignette what they would think and feel, and ideas they might have about treatment or pathways to care. So we did use a mental illness stigma scale to really help understand some of these things. So although kind of a few major types of stigma, which Limor went through earlier today, each type of stigma has multiple aspects, and we wanted to be as thorough as we could. The MIST scale is very good. And so it has 7 areas of stigma. So when we think about anxiety stigma, it's kind of like the anxiety reflects fear, uneasiness, nervousness, or physical harm about individuals with mental illness. So if I'm thinking, what do you think about people with mental illness? I get anxious because I'm worried about them, kind of thing. And that's what that measures. Relationship disruption it assesses the beliefs about the possibility of having a meaningful, healthy relationship with an individual with mental illness, and on they go. So that's why we use the scale. It gives us a bit more nuance and depth in our findings. I'm going to talk about, this actually studies is, we submitted this article to a journal on review now. And here we focused on suicide. A total of 242 individuals took this part of the overall project, focused on suicide. And we found a low to moderate range of stigma in individuals in the community. An interesting thing is 96% of participants reported knowing somebody with a mental health problem. And one of the questions we asked in the demographics beyond gender and age is, do you know somebody with a mental illness? And we went through various layers, like a friend, someone, family member, or yourself. Having 96% reporting knowing somebody with a mental illness is really unusually high. I've not seen that in any other community sample or a project I've done. Typically, it's around 50%. So what it speaks to me is in the Jewish community, there's a very clear and strong awareness of mental health issues, and that's a good thing in a number of domains. We did find in the suicide one no differences in stigma based on participant demographics, including religious denomination, whether they were conservative, Orthodox, or Reform, and how often they may have attended religious services. We did find that participants endorsed lower relationship anxiety stigma for adolescents who are suicidal. So if the story in the vignette was about a 15-year-old, that stigma was much lower for them. However, it was much higher for adults, and it didn't matter if they were 25 or 73. And typically we would have seen a difference in all 3 ages. So if you're younger, seemed to be better. Once you hit a certain adult age, it didn't matter as much. Lower hygiene stigma was, and hygiene is the belief about physical care and appearance of individuals with mental illness. So you might think they're unkept or unclean or dirty or that kind of belief. So lower stigma was reported among adolescents who were suicidal than older individuals. But this was only for males. This was not found for females, which is, it speaks to a gender difference. Participants who endorsed more negative help-seeking attitudes. So as Limor talked about earlier with the various measures we use, one was a person's willingness to get mental health treatment should they need it. And so those that had a more negative view of that and who also experienced more discrimination, we had a small scale about, did they feel a sense of discrimination any time in their past? Because we have found that those who feel that often have different views. So those who did not think highly of treatment and those who had more discrimination held higher stigma generally across the board for suicide. Which is an interesting finding. And females were less inclined about suicide and help-seeking stigma. So again, a gender differences we found there. So next slide. So we're going to come back to some of the implications at the end. Here is now a separate study that focused on different types of mood disorders. And Limor really this is one of her great passion areas in her focus. So she took a lead on this and she'll talk about it.
So we had 243 respondents in this study, and we found that major depressive disorder was associated with a higher chance of recovery than bipolar disorder, presenting with mania or depression. So I'm going to explain that a little. Major mood disorders are major depressive disorder and bipolar disorder. And those are the most serious of the mood disorders. And those were the ones we looked at. And people found, because bipolar disorder can have a mood disturbance with mania when there's very high energy, irritability, racing thoughts, or they can have depression, just like in major depressive disorder. And so we found that people thought that people with major depressive disorder had a higher chance of recovery than people with bipolar. And we had two different vignettes, one presenting with mania and one presenting with depression for bipolar. And we found significantly more relationship disruption stigma, and that was associated with bipolar disorder with mania. And that was significantly more than people found for major depressive disorder. And finally, we found more hygiene stigma associated with major depressive disorder than bipolar disorder with mania or depression. And that was people thinking that someone was unkempt and dirty and not taking care of their hygiene. And here we have an interesting interaction that we found that was based on gender and age. And so this is the treatment professional efficacy, or an efficacy scale, meaning, do people believe that treatment works? Do they believe that professionals in mental health are effective? And as you can see, for males, they're the dotted line, that younger males, age 18, had very low beliefs that treatment was effective. And that there's a trend over time that as they got older, males started to believe that, yes, treatment is effective. And among females in the straight solid line, we see that pretty much across ages, they have higher beliefs in treatment efficacy. And on this, this graph right here, 0 is the mean score that we have for beliefs in efficacy. And in terms of perceived stigma, that was what people think, most people think about people with mental illness. Older respondents had slightly less stigma than younger respondents. So they were a little less thinking there was stigma out there. And individuals with personal experience of mental health problems expressed a higher perception of stigma toward people with mental illness. And finally, there was an association between denomination and personal experience with mental health problems. The total sample was 53% of the sample said that they reported they had personal experience with mental health problems. In the conservative sample, it was only 39%. I'm going to take this one, Dr. Gearing.
So this is the third study we did within the larger project, and this was looking at stigma across 4 categories of mental illnesses. So we looked at anxiety disorders, then depressions, then schizophrenia, and finally alcohol use disorders. So those are 4. We chose them based on some of the feedback we got from our community advisory group and the needs of the community. And we looked at them across a number of domains. So a total of 317 people entered various vignettes related to these ones. And what we found is when it came to hygiene related stigma about thinking a person was unclean, or that the least stigmatized vignette subjects were those who had anxiety disorder. So when it came to depression, alcohol, or schizophrenia, they were certainly higher, but anxiety was the lowest. When we looked at relationship disruption and anxiety stigma, the highest stigma was for alcohol abuse and schizophrenia, followed by anxiety and depression. Now, this is interesting. I'm doing similar studies in a number of different settings. Often alcohol abuse is not stigmatized at all. Like, people see it in communities, various communities, as a problem, but it's often accepted as a norm in society because people drink and have, and that's kind of considered the norm. But within the Jewish community, alcohol abuse was seen almost as equal as schizophrenia, which is one of the most chronic and severe of all the disorders, which is very unique. When we looked at treatability-related stigma, stigma again was seen highest for, like, would this person respond to treatment? That's kind of what this treatability stigma is. It's the belief about mental illness treatment. So stigma was highest for those with schizophrenia and alcohol abuse, which is, again, quite surprising to see. Lowest for depression, anxiety, which is not unexpected because although depression and anxiety are the highest two categories, they're often the most readily treatable ones. And when it came to recovery stigma, which is seen as measures recovery beliefs about an individual's mental illness, schizophrenia and alcohol abuse were most stigmatized again. Very interesting that. Overall, we found that female respondents or individuals with a history of mental health problems expressed less stigma about treatability. So females were more positively inclined to think that around the treatment potential, and those who have gone through something were more positively inclined. When it came to older respondents, were more stigmatized in the domains of hygiene and visibility, but less stigmatized in professional efficacy. Respondents with higher frequency of attending religious services, so not whether they were Orthodox or conservative reform, but how often they went, so attending more often, were associated with lower visibility related stigma, but they had a higher stigma around professional efficacy, which is often not uncommon in other communities. The more people attend religious services, there's a thought that treatment efficacy is less likely. Okay, so we're going to go into some implications around some of these issues, and Limor?
Yes, okay. So first off, demographics. We found that across ages, females have less stigma for treatment and professional efficacy. And we found that younger and middle-aged males were less likely to seek help. Diagnostic. Alcohol misuse was regarded with stigma comparable to schizophrenia in the Jewish community, and this is not found among other cultures. And individuals with bipolar disorder are viewed as disruptive to relationships and less likely to recover, and that may limit their social support. And finally, the community. Respondents who attend services more regularly have higher stigma towards mental health professionals. And individuals with personal experience of mental health problems endorse higher levels of perceived stigma in the Jewish community. So our core implications for the Jewish community are: first, we can customize interventions for suicide across specific mental health disorders, domestic violence, and substance use by gender and age. Because we found that younger males in particular are less likely to seek help, we could tailor interventions to them to help them. And we want to increase community-specific psychoeducation, for example, different suicide, bipolar disorder, on acute states, on recovery, and on help-seeking benefits and the harm from stigma. And we want to consider using peer interventions to humanize mental health problems and meet recovered individuals in the community. And finally, we want to improve pathways to care within the Jewish community, both formal ones and informal ones. Oops, that's what I think this is. But Dr. Gearing, do you want to cover this?
We have not, although we've this first phase of the Jewish Mental Health Project, phase 1 was in Houston. That's, as I said, done and wrapping up, and we're just finishing the final analysis. We have to still complete the analysis on domestic violence, so we have yet to get to that one, and that's, if there's of interest, we'll try to get that information out to everyone as well in the community. We're looking to disseminate the findings to the various places and centers and organizations that work with us in the Jewish community. So providers on the ground and individuals who can hear the results and then not just go to like academia or just clinicians. We are reaching also out to mental health professionals and agencies to share these findings, as they might help inform future practices in a way that's being more targeting. We'll also be sharing and are sharing some of the research and practice findings to the larger communities, both nationally and internationally. And this does, as Limor had mentioned, a lot of real solid practical implications. We think of how to reach out and destigmatize some of the issues around mental health even greater. We know that the more the stigma is, the less people will reach out for treatment, and more likely they're to suffer and less likely to recover. So helping the large community on public awareness issues, thinking about how to target treatments around certain diagnoses, or when we think of pathways to care, does that differ for certain conditions or males or females or certain ages? All of that, we're beginning to get some really unique insights to the Jewish community that we just didn't have before. Research hadn't really focused on these things. So that's kind of exciting. We're just beginning the starts of phase 2 of the project, which is doing this comparable a project in both Israel. So one of our partners on this is Dr. Dave Rowe from University of Haifa, and in New York. Like, not every Jewish community is the same, and being able to show differences across the US and across the world, I think will really add to a greater sense of how to be more supportive and helpful in addressing stigma and managing mental health issues and treating them within the larger Jewish communities. So with that, I think we have come to the end of our formal presentation. Certainly want to thank everyone for listening through it, but we're happy to answer any questions or respond to the findings, or we could talk about the weather. All's good for us.
So if anyone has any questions, you can feel free to unmute yourself, or if you feel more comfortable, you can certainly post questions in the chat. I do have a question to start off. Do you guys believe that the high rate of knowing you mentioned that, more people in the study of the Jewish community were aware of someone with mental health issues. And I'm curious why you think that is. Do you think that those in the Jewish community are possibly more aware of mental health due to the awareness through JFS, through the synagogues, et cetera? Or is there another reasoning that you feel that the Jewish community has such a high rate of knowing someone?
I guess I'll take this one. There is a bias in how we collected our data. We always try the best we can, but there's always issues like that. And people knew it was a study on mental health issues, and that attracted people who knew about it, who were interested in that. And so that's part of it. But still, we had such a high number that I think part of what you said as well is true. I think we do have a good awareness of it, but I also know that we had a selectivity bias in who filled out the surveys.
And all of what Limor said is correct, but on the face of it, it shows that the Jewish community has a greater awareness that mental health is health and part of whom we all are. Now, what we found too is, in not just this, but other research, is familiarity can lead to the decrease of stigma, but it can also lead to the increase of stigma. So it's not just simply a one-sided coin, but it's an important finding that mental health is just an element of all of us.
I have a question. You focused on, in the results, differences between different groups or different vignettes, but you didn't say anything about the absolute level of stigma, if it was very high are very low, or how that might compare with other communities. Because if you've got, two comparisons of very low and low, that's not a whole lot of stigma, as opposed to very high and very low. So I'm wondering if you could talk a little bit about how much actual stigma there was overall and in the different groups.
Did you want to start with that, Limor, or do you want me to start?
I think you can handle it.
Thank you. Well, there is stigma. Every community has stigma. The Jewish community in Houston has stigma when it comes to mental health disorders, so it's just there. And so when it's hard to compare apples to refrigerators, and so it would be challenging to compare, because we only looked in this study at this community in this way. We would have had to expand, and we're looking to do that. So for example, in the Israeli study, we're looking to expand it to 3 communities within Israel. We're going to look how I planned tentatively, this will be a 3-year project, and we have currently funding for the first year, so we're going ahead with that. But we're looking at 500 Orthodox individuals in the Jewish community in Israel. We're looking at 500 secular individuals within the Jewish community in Israel, and we're looking at 500 Arab Israelis, and seeing a comparison. And because we're including all of the study, we're going to do random the vignettes across all of those populations. We will be able to really compare those different responses on stigma across the board. So to partly answer your questions, and this is a researcher, me not wanting to go beyond what the research tells us. Yeah, the Jewish community does have stigma. In some areas, it's kind of unique, as we've shown, and the comparison was really how is it manifest within the community. Is it like off the charts compared to, no, that would be a general kind of like, we're not seeing it extreme, but very rarely would we see it extreme. There's certain bias when people do these things, that there's a worry about how others will perceive. And so we always ask questions around, how would you think about these issues? And then we would say, how would others in your community think? The same kind of questions. And typically what results is people are saying, well, I don't have stigma, but others in the community have stigma. And then we would get a sense of that way. Now, conversely, there's a part of the community or individuals, like I've been working in mental health for 30 years. I know full well stigma exists. I've seen it in my practice and my research for just ad nauseum. And so somebody said to me, Robin, do you have stigma when it comes to mental health? I would say, I hope not. Most of that I think I've eradicated. Do you think others do? And I'd be like, oh, absolutely. So there is a small percent of people who are very familiar with the mental health issues in the community and the impact that means on, who would recognize that they have lower stigma, but the community might have larger just out of knowledge base. And then it's trying to suss out between that group and the other group who's saying almost political correctness, no, I don't have stigma. No, everyone else does, when we know full well that that's not true. It's a long-winded answer. Hopefully I answered elements to your question.
Any other questions from the group? Of course, as I said previously, you're more than welcome to put them in the chat if that's a more comfortable situation. I see someone has unmuted themselves. Jean?
Right. Hi. I'm not a researcher, but I've followed along as best I could. My interest is the implications for treatment. Do you have any indications that for the Jewish community to be more likely to seek treatment would be in a Jewish focused setting? I mean, it's hard to say, but if there's less stigma in the Jewish community on mental health, are they more likely to seek treatment?
Okay, that's a great question. And we're actually, we're looking at the pathways to care, which is where do people in the Jewish community seek out help?
Right.
And, would it be a and we can look at, is this a traditional, like Jewish service, or is it a more, because from the data in, like, when going through it, I want to be tentative. I've looked at responses that I've seen clusters around where they've like, yeah, I'm not going to go to the Jewish community because they know me. And so I don't want that to happen. But there's been other people who say, no, I'm absolutely only going to go to the Jewish community because they know me and it'll be better for me. So we've seen both of those things. It'll be interesting to see how the analysis shows that, does that pathway differ by denomination or age or gender or knowledge of certain elements of mental health? And does it differ if they start off in the informal network and then go to the formal network? So the short answer is yes, we are able to answer many of those questions you just posited. We don't yet have those full answers. The analysis is not yet complete on that. I think what we wanted to do is we've done more, about 70% of the analysis so far. We wanted to start sharing that before so much time has passed that people forget about what we're doing. And down the road, if we're getting a lot more interesting findings in some of those ones remaining, like on domestic violence, which we have yet to do the analysis on, or the pathways of care, we'll try to have forums where we can bring back that knowledge to.
And of course, we all know that there's not such a thing as domestic violence in the Jewish community, right? Anyway, well,
You can agree with that.
I think your work is brilliant, and I'm looking forward to seeing it continue. Because I do in my own practice find that people always ask, well, are you Jewish? Like, I want to come because you are. But I'm finding referral outside of private practice there's a huge paucity of treatment options I'm just aware of the Jewish community. I would like to see that come to some growth out of your research. So there you go. There's a goal for you.
Thank you. It's a great goal. If there could be more resources and services provided,
Huge.
that would be
Yes.
wonderful.
Yes. I support that. Good job.
Last chance for questions. Dr. Gearing and Limor, I wanted to make sure for people who wanted to keep tabs on your research that before we ended our time, what's the best way for, and I'm happy to share this with our folks as well, A, to get in touch with you, or B, to keep tabs on what's going on as you move this forward to the 100% from your 70%.
Limor, do you, maybe we can put in the chat box our contact information. If people want, they can reach out to us, and that's probably the easiest way. And sometimes people will let us, when are you going to give another talk and about the next, and we'll try to keep lists to let people know of that as well.
Yeah, I just wanted to also chime in. I mean, how grateful we were at the congregation to be part of this. I think just doing the study, right, and providing opportunities helps to lower some of the stigma and to normalize mental health as health. And so I think we were so thrilled that you asked us to be part of it and that we could be good partners with it. I think especially during the last 18 months, the issue of mental health awareness. So it was sort of nice, like we participated in this, and then this, I think, more talk in the media and more, I think, light has been shining on people, especially because of the pandemic. It sort of gave people permission to be struggling with mental health in a more open way than before. And because our congregation had seen us put this opportunity, our community as a whole saw us put this opportunity out for everybody, I think it became, just a little bit safer, a little bit more common. And so I just want to thank you for inviting us to be partners and providing us the opportunity to share this and to really provide a jumping off point for not only our congregational, but professionals who are on this call. And, the more we talk about it and put things out there, I think it helps for those who are experiencing mental illness and to sort of lower the some of the barriers of discussing that and seeking care.
And I certainly want to say thank you. I will say the community has been just wonderful in allowing us and supporting us and getting access in so many different ways. And this is a hard issue. We're not talking about easy things. We're talking about domestic violence. We're talking about mental illness. We're talking about suicide. And these are hard topics. And yet we found, doors across the whole community were continually open to us and quite supportive. And that I will say, I wish that was true of every community I get an opportunity to go and do some work with. But it was really, it was just warming to have that to occur. So.
Rabbi Silk, I wanted to follow up what you said, because I think you're a pioneer in our community, because it was a few years ago on Yom Kippur, Rosh Hashanah, I think it was Yom Kippur, that you gave a sermon and you talked about mental illness. And I can't tell you how happy I was that you did that. And I think that it was just exactly what you said. It kind of sets a tone for people to be able to talk about it, to be able to feel a little better about the fact that they're dealing with this. And so many people are. I mean, the statistics are that, it's a huge statistic. About 1 in 4 or 5 people has a mental illness, and about half of all people will experience a mental illness in their lifetime. And so normalizing it and encouraging people to get help, I just want to say how proud I am of the Jewish community for doing that. And I hope they continue, and I hope it grows. Thank you.
All right. Well, I think that wraps up today's program. Again, I appreciate the participants coming on. I thank Dr. Gearing and Limor for coming on. I think this was a great 45 minutes of our time together. And as always, be on the lookout for other happenings at Emmanuel around the topic of mental health. And anytime we can participate with Dr. Gearing and Limor, we'll certainly jump to it. So thank you again, everyone. I did post the contact information in the chat. You can certainly reach out to me if you need it as well. And thank you again for your time today.
Thank you, everyone. Have a great day.
Thank you.